I'm not going to tell you. Someone that is designed for this program will tell you more about that. Please join me as I welcome upstage the Executive Secretary of Osun Health Insurance Scheme, Dr. Adeni Ogini. Put your hands together as we have the section together. Thank you, Dr. Ogini. Please, can you bring the slides up? Yeah. The president of the Living Science Foundation, distinguished participants are here this afternoon. We're here to discuss the topic of keeping the universal health coverage promise on cancers and NCDs in Nigeria. The outline, next slide. I will be talking about the burden of cancers and NCDs. I would not bore us too much because I think Professor Sridhar did very good justice to the burden of cancers and NCDs in Nigeria and then, of course, even globally. And after that, I'll let us know about the history of universal health coverage. And thereafter, we'll talk about Nigeria's efforts towards achieving universal health coverage. We'll particularly dwell on the National Health Act 2014 and the Basic Healthcare Provision Fund. Now we'll talk about the high points of the universal health coverage, the promise of universal health coverage. And then we'll talk about strategies for keeping the promise. It's not going to be a very long presentation. The burden of cancers in Nigeria. Major NCDs in Nigeria include cardiovascular diseases, hypertension, coronary heart disease and stroke, cancers, diabetes mellitus, sickle cell disease, chronic respiratory diseases, mental and neurological diseases, even road traffic accident now has come to be classified as part of the chronic non-communicable diseases in Nigeria. We have also oral health as part of it. Now, non-communicable diseases kill approximately 40 million people globally each year. And about 9 million of these deaths are premature, occurring before the age of 60. And we know that cancer is the second leading cause of mortality globally. It claims more than 9.6 million lives in a year. Now, the important thing that I want us to also realize about cancer is that it's a disease of inequity. It's a disease of inequity in a situation where certain people in certain populations are worse affected than others. Now, in 2018, Nigeria recorded 115,950 cases with a mortality of over 70,000. Premature deaths from NCDs were 289,000, while about 18% of that was due to cancer. And we can see this is just the burden of cancer and non-communicable diseases, other non-communicable diseases in Nigeria. Now, low and middle income countries are particularly affected by non-communicable diseases. We know that more than 80% of all deaths from NCDs all over the world, they occur in low and middle income countries. And NCDs are projected to be the most common causes of death by the year 2030. Now there we will see some of these things which I've stated. There's a progressive epidemiological transition. Professor Sambo already told us about this epidemiological transition. Unfortunately, we are not transiting yet. We have one big burden. We have not overcome that, and we have adopted, we have actually acquired a new one. The non-communicable diseases that we are having now is as a result of our, adopting the Western, civilization, the Western pattern of feeding, of eating, of living our lives. But our own communicable diseases that we have been with for years are still with us. We haven't overcome them yet. So we can't really say we're transiting, but we have a double burden of diseases. The double burden of these, as we talk about, we are still battling with. NCDs are leading cause of morbidity. Yes. Hypertension prevalence is by 11.2. That was 1992. Now, recent studies, you can see that about current estimate is about 20% and 28.9% in 2014. In fact, we did a small survey and we found out that 4 out of every 10 Nigerian adults had high blood pressure, and that is quite serious. The cancer incidence is this, with this number. Diabetes prevalence was 2.7 in 1992. Now, in 2016, the profile shows that it is 4.3%. It is so bad now that even, young people, adolescents are developing, not even adolescents, people that are within the age of 8 and 12 are also developing. I was at a conference in Lagos, and the pediatric, a pediatrician was saying that between 8 and 12 now they are having people, because of gross obesity, as a result of this affluent living, gross obesity is causing them, is predisposing them to diabetes mellitus. That is juvenile diabetes mellitus. Now, sickle cell disease prevalence is also, very high. And yes, next slide, please. Yes, asthma, we know, is killing quite a lot of people. Chronic obstructive pulmonary diseases prevalence is as high as 7.7, and mental health disorders seems to be increasing almost on a daily basis. Next slide. Next slide. Now, the financial burdens, because we are talking from the viewpoint of healthcare financing, the financial burden of NCDs and cancers is such that you cannot ignore. If you want a functional health system in Nigeria, you must attend to these conditions, non-communicable diseases and cancers that affect such a huge number of the population and a huge proportion of the population. Now, accessing treatment and care for cancers and NCDs are usually very expensive. Very expensive because for NCDs, the patients must be on drug on a regular basis. They are on drugs daily. Now, it also requires some technicality that you need, very highly specialized people to take care of these conditions. So whether it is in private hospital or in public sector, you need a lot of money to take care of non-communicable diseases and cancers. Now, the National Health Act, the National Health Account between 2010 and 2016 estimated that 3.7 trillion naira was spent on health, of which 2.8 trillion, that is 75%, came out of pockets. Now, this is very important, and it's even worse in Osun State. A study that was conducted in our state showed that 82% of healthcare expenditure actually came from out-of-pocket expenditure. And that, for many families, was far above the 10% of the entire household expenditure. Next slide, please. Now, why did universal health coverage, why did the concept even, arise in the first place? We will know that from the time that WHO was established, right from 1948 coming down to 1978, the world has always sought different means, different strategies to make sure that health is available for everybody, everywhere they are. We started with the Health for All by the year 2000. And then between 1978 and year 2000, for 22 years, the whole world was grappling with Health for All by the year 2000. Year 2000 came, and alas, there was no health for all. And so the world started different other strategies. We'll see from here that what is EHC? The universal health coverage is actually nothing different from what was captured in Alma Ata in 1978. That everybody, everywhere they are, wherever they live or work, will have access to qualitative health care. And that this health care must not, accessing this health care and paying for it must not, cost those individuals accessing the care any form of financial hardship. So we're talking about access, we're talking about quality, and we're talking about financial risk protection. Next slide, please. Now, the history of UHC. Universal health coverage is firmly based on the WHO Constitution, like I said, in 1948, declaring that health is a fundamental human right. That is the first, that's the underpinning, philosophy of universal health coverage. That health is a fundamental human right. Right from 1978 to 2015, you'll see some of the history there. Now, it cuts across all health-related sustainable development goals, and it brings hope of better health and protection for the world's poorest. Now, let's go to the next slide. Yes, this is the way it went. On December 2012, the United Nations General Assembly endorsed a resolution on global health and foreign policy, urging countries to accelerate their progress towards universal health coverage. That was in December 2012. And now every December 12th, all over the world, we celebrate the Universal Health Coverage Day. Now that started from the United Nations General Assembly that endorsed that resolution. On the 25th of September in 2015, the resolution of transforming our world, the 2030 Agenda for Sustainable Development, also was put in place. Now SDGs came up with a very ambitious, goal also in different areas of human endeavor. But the ones that we are going to be talking about is the Sustainable Development Goal 3, which in the Target 4 says that it wants to reduce by 1/3 the mortality from non-communicable diseases through prevention and treatment. That is Target 4 of Sustainable Development Goal 3. Now, if you look at the Target 8 of Sustainable Development Goal 3, it talks about seeking to achieve universal health coverage by 2030. Now, what that means is that they are saying that by the year 2030, everybody that lives everywhere in the world, including the people that are in Orogi, the people that are in Sokoto, in Atakuma Sahis local government here in this state, and the people that are in far away, Ifedayu and things, that everybody will have access to care whenever they need it. And that care will be of a quality that will guarantee the desired outcomes. And it must be at a cost that will not cause them financial embarrassment. Now, is that possible between now and the year 2030? That is what we have come here to see. How do we keep the promise of universal health coverage, particularly as it relates to non-communicable diseases and as it relates to cancer? Now we see that on the 12th of December 2017, the United Nations passed a third resolution on global health and foreign policy, addressing the health of the most vulnerable for an inclusive society. Now when we're talking about an inclusive society, we're talking about a society where no man is left behind, where every man, as far as accessing care is concerned, we're all, on the same, page. Now, can we, to the next slide, please? Next slide. Yes, thank you. Now, each year on the 12th of December, universal health coverage advocates raise their voices to share the stories of the millions of people that are still waiting for help. Like, this is another forum where we're talking about the gap between those people who have access to care and those people who do not have access to care, particularly as affects cancers and NCDs. How do we, rising from this meeting, what are the things that we'll say that will help to, bridge that gap and get access to those people who are living with NCDs? Now, of course, we champion what we have, achieved so far. Call on leaders to make bigger and smarter investments in health. Now, what we're going to be talking about, we'll talk about bigger investments on health. I'll just run us through some of the things. Now, it's also to encourage diverse groups to make commitments to help move the world closer to universal health coverage by the year 2020 next. Now, what is the story like in Nigeria? How did it start? What are we doing in Nigeria to see that we achieve universal health coverage by year 2030? Nigeria's commitment to UHC has been symbolized by the passage of National Health Act 2014, which is a milestone in the national momentum. What was it meant to? It was meant to strengthen Nigeria's health system. Like the health system was defined as everything that is involved in ensuring that people, live healthy lives, not just lives that are, devoid of sickness and disease, but lives that are economically and socially productive. So to strengthen the Nigerian health system, to achieve universal health coverage, to improve the nation's health indices with a consequential improvement in economic productivity, and in Section 11, the National Health Act 2014 established a basic healthcare provision fund which is meant to support the effective delivery of primary and secondary healthcare services through the provision of a basic minimum package of health services. Now, I'm going to explain this one further. And then, of course, an emergency medical treatment. Now, if you look at the COVID-19, which we have had, and some of the other epidemics that we have had in the past, this provision of the emergency medical treatment gateway of the basic care provision fund is supposed to make huge funds available to be able to now first prepare, before the epidemic, comes, and then, of course, to respond appropriately to the epidemic. Next slide, please. Now, in accordance with the National Health Act, the basic care fund is derived from an annual grant. An annual grant from the federal government of Nigeria of not less than 1% of its consolidated revenue fund. Grants by international donor partners. I was talking in the morning and I said, in the health insurance pool, there is room not only for formal sector contribution from civil servants or public servants, not only from governments, there's also room from international donors, development partners, and spirited individuals, good-spirited individuals and philanthropists who might want to put money for specific conditions to be taken care of. And those are the kind of innovative financing that we're going to be talking about when we talk about expanding the benefit package of the Basic Care Provision Fund or any of the social health insurance agencies, schemes, to accommodate all of those esoteric conditions. Now, funds from other sources, which are inclusive of the private sector. Now, these funds from other sources will include telecommunications funds, will include the sin taxes, and other innovative means of raising revenue to ensure that money is available in the health insurance pool to be able to take care of some interventions. Now, its implementation is aimed at increasing the fiscal space for health, strengthening the national health system, particularly at the primary healthcare level, and ensuring access to care for Nigerians, particularly the poor, contributing to the overall national development. Now, let's go to the next slide. The National Health Act in 2014 requires the definition of a basic minimum package of health services for all Nigerians. Now, not just that alone, it also requires the establishment of a functional state primary healthcare development agency, as well as a functional state social health insurance agency in each state of the Federation and the Federal Capital Territory, and the identification of one focal primary health care ward to be accredited for provision of primary care and referral services for all Nigerians, especially the vulnerable. Now, I will stop there a bit and then let us know. What we're talking about here is that for Basic Healthcare Provision Fund, which is a development and a new, paradigm in the Nigerian health sector that originated from Section 11 of the National Health Act 2014. There are some things that are needed for it to be functional and operational. One is that there must be a functional state primary healthcare system that is very functional. 2, there must be a state social health insurance agency. 3, there must have been identified focal primary health centers in one ward in each, in one focal health center in each ward of the entire nation. So we're talking about all over the, Nigeria, 772 local governments, all of the wards. There must be at least one focal facility that will be benefiting from the basic healthcare provision fund to strengthen the primary healthcare system such that it will be responsive to the people that are living within the catchment area of that focal primary health center. That's how it's intended to really operate. Now, its implementation is to be based on a set of guidelines which stipulate the governance, the administrative and funding and monitoring mechanisms for the fund. Ladies and gentlemen, many years ago, at some of our national conferences, I tell people that the problem with Nigeria's health sector is not absence of funds. And I will just get to let you know some of the things. Next slide, please. That the overall objective, yes. The overall objective of basic healthcare provision is to ensure the provision of a basic minimum package of health services to all Nigerians and strengthen primary health care. Now, based on that National Health Act 2014, 50% of 1% consolidated revenue of the federal government is supposed to be put aside to take care of basic care provision fund, basic minimum package of health services. Now, of that 1%, 50% of the 1% is supposed to go to the National Health Insurance Scheme via a pathway that is called the NHIS Gateway. That NHIS Gateway trickles down to the various state health insurance schemes. So NHI is supposed to get 50% of the concentrated, 1% of the concentrated revenue of the federal government, and is supposed to now send it to the 36 states and the Federal Capital Territory. That is NHIS Gateway. Now, this is supposed to be used to purchase the services that are captured in the basic minimum package of health services as determined, by the implementers of the scheme, the Basic Care Provision Fund. Now, it will purchase this from accredited providers nationwide, and these providers will include both private and public providers. Next slide. Now, the disbursement of the 45% is through the National Primary Care Development, Agency Gateway, and it is meant. Now, you can see what is happening. This is Nigeria's efforts towards achieving universal health coverage. Establishing primary health care, state primary health care development agencies. Yes, they are already there. Now, they are supposed to select one focal facility per ward. Now, this one focal facility per ward will get this amount of money. You can see what's happening. The provision of the essential drugs, vaccines, and consumables for eligible primary health care will be 20%. Last year, December, 420-something million was sent to the State Primary Care Development Agency to do this. In this state, we were the first state in the entire nation that got this money because we were the only state that actually piloted the Basic Care Provision Fund. Now, that will be used for medicines. So the situation of coming to the hospital, the primary health center, and they're saying there's no medicine, particularly for the vulnerable. I keep mentioning particularly for the vulnerable because I'll let you know why we have to get there. If everybody that attends the primary health center is going to access this, then there will not be enough funds even to take care of up to 1% of the total population. But then if it is segmented into the vulnerable population, then we know that those who are vulnerable can access care at those primary health centers based on this fund, the Basic Care Provision Fund that has been provided, by the National Health Act 2014 in Section 11. Now, 15% of this will be used for the provision and maintenance of facilities, laboratory equipment, and transport for eligible primary health care facilities. So you can see, right coming from national, 15% is already provided for maintenance of facilities. This is an innovation. This is something that never happened up until the time that National Health Act 2014 was passed into law. And then development of human resources for primary health care will take 10%, and the last 5% will be devoted to emergency medical treatment. Yes, next slide. Now, this is a picture of how disbursement, the money was appropriated. I said, despite all odds, between 2014, when the law was passed, and 2018, nothing was done until December in terms of appropriation. So we can see that there could be a law existing, but there needs to be a political will for you to make that law effective. And this was what Senator Lanre, Teju Osho, Senator Ibrahim Olori Egbe, all of them in the last National Assembly came together with many CSOs, non-governmental organizations and civil society. They pressurized the National Assembly to ensure that they appropriated for the first time in 2018 56.5 billion naira. Now, this 56.5 billion naira was appropriated to serve as the basic healthcare provision fund in Nigeria. We were supposed to receive the first tranche of this money by January 2019. Ladies and gentlemen, as I speak to you, not one kobo of this fund appropriated in 2018 has been released to any state health insurance agencies in this country.